So it's 4 o'clock and we'll get going. Welcome everyone to another edition of Tumor Talk. As the collaborative effort between Lenox Hill Neurosurgery, the Journal of Neuro-Oncology, the Tumor section, Springer Nature, now Cassini, a whole slew of people, where we bring recent publications in the journal, and we have the authors themselves present really their rationale, their results, and the relevance of their studies, to the population at large and whoever's watching. So we are pleased today to have Gino Cioffi and Carol Kruchko with us. And I'll let you guys introduce yourselves and take it away. We can dive right in. Welcome.
Right. Thank you very much. I'm Carol Kruchko, president of the Central Brain Tumor Registry of the United States, known as CBTRUS. And I'm very thank you to Randy and to Jason to allow us to showcase our recent publication in the Journal of Neuro-Oncology during this webinar today. Our CBTRUS team, led by co-scientific principal investigators Dr. Jill Barnholt-Sloan and Quinn Ostrom, we're dedicated to utilizing our database to provide contributions to the epidemiology of brain and other CNS tumors. So this presentation today focuses on changes in survival over time for brain tumors that Gino from our CBTRUS team will be giving, and it shows the utilization of our data. So thank you.
Hi everyone, I'm Gino Cioffi. I'm a biostatistician that's affiliated with CBTRUS. I'm also a contractor with the National Cancer Institute in the Division of Epidemiology and Cancer Genetics. For this, should I share the presentation on my end, or is it?
That's correct, yeah.
Perfect.
Best that way.
I will get that all ready. All right, how's it look? Everything showing up?
Looks great.
Looks good.
All right, perfect. So as Carol mentioned, our presentation today is over our recent manuscript, Changes in Survival Over Time for Primary Brain and Other CNS Tumors in the United States. Just to kind of begin, I'm going to go over some of the general brain tumor statistics that we include in our Central Brain Tumor the Registry report, our annual report. So overall, for brain tumors incidence statistics, we see the vast majority of brain tumors are classified as non-malignant, with the most common being meningioma. And then for malignant tumors, it's a much smaller proportion, with the highest incidence being glioblastoma, which is unfortunately a very aggressive tumor. And we see quite a bit of difference in overall incidence by age, which is something that we'll comment on with the analyses that we included in our study. So overall, we can see that adults tend to get a much higher incidence of brain tumors. But when we look at the distribution of malignant versus non-malignant brain tumors, we can see that in the child population, the proportion of malignant tumors is much higher than non-malignant tumors. And they also have a very different distribution of types of brain tumors that will develop, and we'll talk about that a little bit as well. So here we have kind of some incidence statistics by specific histopathology that we see in cases in the United States, kind of over across the age group. So we see explicitly in adults, as patients get older, the incidence of glioblastoma gets much higher. For children, we see that in tumors of the pituitary. We also see, as in some instances, incidence gets lower as people get older. So brain tumors kind of have an interesting bimodal distribution, where there's high incidence in kids and kind of gets lower, and then it gets high again in adults. So here we have some survival statistics that we included in our annual report, stratified by age. And you'll see that the distribution of brain tumors of interest vary wildly across age groups, particularly ependymal tumors and embryonal tumors are much more common in the pediatric cases, as opposed to the adult cases where we're much more focused on glioblastoma and other forms of glioma. And in general, we can see, based on these survival curves, that the survival probability in adults is much worse. So as people get older, the survival probability drops pretty significantly, with the lowest survival in our pediatric group being other astrocytomas, kind of leveling off, around that 30% survival probability. And in our 40+ group, we see much lower survival outcomes in our glioblastoma patients. In general, for brain tumors, we don't really have a single risk factor that accounts for them overall. So for some tumors, we have inherited disorders that are associated with single genes that can increase the risk of brain tumors in both children and adults. There's also some evidence that shows that ionizing radiation to the head can also increase the risk of brain tumors in children and adults. Interestingly, there has been evidence that shows that a history of allergies can lower the risk of brain tumors in adults. And there are some genetic risk factors of germline variants that have been performed in GWAS studies, but only in adults. There's been a lot of talk about certain environmental risk factors related to brain tumor incidence, but not a lot with, that have currently been, I guess we could say, proven with significant evidence. Commonly talked about are cell phones, but there's also quite a few other different environmental risk factors that are often talked about in association with brain tumor incidence. In general, for survival, we see that as patients increase in age, which we talked about briefly, survival outcomes are worse. In general, we also see that females tend to have better survival outcomes than males. And in regards to race and ethnicity, Black non-Hispanic patients tend to have worse survival outcomes. Survival is also, highly related to the site and the type of tumor that it's diagnosed in. So we report in CB Trust that tumors of the parietal lobe have, the worst relative survival outcomes. Something to note: these are highly correlated with the types of tumors that occur in these areas. And we saw that, the best relative survival in that of the acoustic nerve. And for specific histopathologies, we see that glioblastoma has the worst relative survival of only 6.8%, compared to something like pilocytic astrocytoma, which has 94.7% relative survival. In general, for treatment, it varies widely by the type of brain tumor, but in general, we see radiation, chemotherapy, and then extent of resection. So in terms of surgical outcomes, for tumors that receive surgery, the more tumor that is removed, the better survival outcomes that people will see with treatment. In general, we have some standard of care. So for glioblastoma, the STOOP protocol, which is radiation with concomitant temozolomide, does impact glioblastoma survival outcomes, and we see better survival for these patients. So for our study, we had received data in partnership with the Center of Disease Control and Prevention from their NPR survival data set. So their NPCR is the National Program of Cancer Registries. It consists of 42 registries that covers approximately 82% of the US population. Our histopathologies that we classified is based on the classifications that CB Trust has defined in that annual report that's in partnership with a team of expert neuropathologists. And what we looked at was survival outcomes from 2004 to 2017, and we split those up into 3 groups, just relatively equally distributed across the time period, just to kind of group people in like an earlier, middle, and later time period. As we talked about previously, survival outcomes for brain tumors and the types of brain tumors that people are diagnosed with vary wildly across age. And so we stratified all of our analyses by age group. So we have 0 to 14 years, 15 to 39, 40 to 64, and 65 plus. So this really kind of represents our pediatric, adolescent, young adult, and then older adult population. And so for this study, we performed some univariable Kaplan-Meier survival curves, and then also performed some age-stratified multivariable Cox proportional hazards models to adjust for some other potentially confounding variables. So in general, what we found is that particularly for primary malignant brain tumors, we see that there was increased survival outcomes in all age groups by time period. So in these survival groups, kind of the green line is the time period that's the most current, so 2013 to 2017, and the blue line would be the oldest time period, so 2004 to 2007. So for non-malignant tumors, we do see some increased survival outcomes in the children, adolescent, young adult, and older adult populations. Something to note with these survival curves, because non-malignant tumors tend to have, in general, better survival outcomes, they tend to have higher overall survival probability for those groups. So these scales are actually a bit different for the malignant and non-malignant, just to note the differences so there isn't any confusion. These graphs are cut off at about 85% survival probability, where the malignant plots go all the way from 100 to 0. So as we commented before, we see a very big change in the incidence of specific types of brain tumors across age groups. So we thought it was important to evaluate the differences in this survival over time by specific histopathology for the relevant histopathologies that we see in these age groups. So essentially we took the 5 most common histopathologies for each age group and analyze this same survival difference over time. And we did see quite a few differences across different types of tumor types. So for the pediatric group, we saw improved survival outcomes for embryonal tumors. For the adolescent young adult population, we see improved survival outcomes for anaplastic astrocytoma, diffuse astrocytoma, and oligodendroglioma. Similarly, for the adult population and for the older adult population, we see these significant improvements in anaplastic astrocytoma. And then for the adult and older adult, we also see improvements in glioblastoma and lymphoma. And to clarify, this is lymphoma of the central nervous system. And then for non-malignant tumors, what you'll notice is we don't have anything reported for this pediatric population. And that's because they do really well, too well that we can't report them. So per our agreement with the CDC, we can't actually report statistics when there aren't enough events. And in this case, that's deaths. So there weren't actually enough relevant histopathologies that it had experienced enough events for us to report those statistics. So in this case, we only report those for the adolescent, young adult, and older adult populations. And we don't really see any significant differences for that AYA group. We do see that for meningioma, there is a slight difference in overall survival over time for that adult population. But for that older adult population, we do see significant differences in overall survival over time for meningioma, mesenchymal tumors, nerve sheath tumors, and tumors of the pituitary. So as we mentioned earlier, we performed Cox proportional hazards models to adjust for some potential confounders. So these models are adjusted for age at diagnosis, we're stratified by age at diagnosis. They're adjusted for sex, race, and then treatment pattern. So if these patients received radiation, surgery, or a combination of both. And what we find is that in general, we do still see improvements in overall survival over time. And so to interpret these graphs, essentially everything that is to the left of these dashed lines indicates improved survival relative to our reference group. So in all cases, our reference group is going to be that 2004 to 2007 period. And so essentially these are hazard ratios which assess our risk of death at any given point in time. So these patients have a decreased risk of death, over time relative to the patients that were diagnosed in 2004 and 2007. So for malignant tumors, we see significant differences in both the year categories for children, adolescent, young adults, and then older adults. And so for just the adult group, it's that 2013 to 2017 period where we do see a slight significant difference between our reference group. And then for non-malignant tumors, mainly we are seeing, kind of as we saw with those, when we looked at the individual histopathologies, the big differences we're seeing in survival over time is for that older adult population, with some slight differences, in the child group and the adult group. So in general, we found that individuals that were diagnosed in later time periods had improved overall survival compared to individuals diagnosed earlier. And due to the nature of this study being like a very broad population health overview, it was out of the scope to really try and make any sort of claims as to why this association was seen. So there's potential improvements in imaging and in treatment patterns, access to care that could contribute to this, but we don't really know based on the information that we have here. So, it'll be important for other researchers, to kind of go out and evaluate this to see, if they can correlate these changes to these findings that we have. But it's important to report these findings because continued monitoring of changes in survival over time really add to the understanding of advances in diagnosis and treatment in primary brain and other CNS tumors that we see here in the United States. And these cancer registry-based statistics provide critical information to physicians and researchers and all healthcare providers, that give us information on disease burden and characteristics that, ideally will lead to improvements in patient care and prognosis. And just some little additional notes. I would first like to acknowledge all of our co-authors on the paper, Dr. Jill Barnholt-Sloan, Dr. Kristen Waite, Jacob Edelson, Carol Kruchko, and Dr. Quinn Ostrom, who all were integral into getting this paper put together. In addition, the Central Brain Tumor Registry of the United States is always open to collaboration. So we have a form on the website if anyone is interested in, if they have any questions that they would like looked into, we're happy to generate statistics with that, or just ideas on potential projects. So please fill out that request form if that's the case. And also, if for anyone that has interest in working at the National Cancer Institute and specifically in the Division of Cancer Epidemiology and Genetics, please check out the DCEG website. Thank you.
Gino, thanks so much. Great job. And I know, Jason probably shares my thought that there's so much we can talk about with this and how important it is. But fantastic job. And I really appreciate you breaking it down nicely for the audience. What's so fascinating to me is that stop point, the data presented till 2017. And I feel just like in the past, 5 years, we've probably, pushed that needle a little further. And, I'm just curious how you guys feel, or is there a plan to update this, and how soon, can it be updated really? How difficult is it to kind of relook at this data, or does it happen in real time?
That's a great question. So in general, cancer registry data is offset by a few years. So it tends to be about 3 years out. Our survival data tends to be a little bit more, I think, to account for the, really assessing and making sure that these survival outcomes are accurate. So in general, currently it is 2022, right? Just making sure I get that straight. So our most recent data release included data up to 2019, and then our survival data was up to 2018. And so it would take approximately, another couple of years for us to get like another substantial chunk of time to see, how things have changed. But we're really interested and we're really curious. And as you know, there's been a lot of events that have occurred in the past couple of years that can impact, patient outcomes. And so we're really interested into looking in that further.
Absolutely.
Yeah, just an incredible body of work and so many questions that could be answered and so many testable hypotheses that could be generated, as you've indicated. And I don't begin to have the answers as to what necessarily has led to some of the positive effects that you've noted in your study. But on the flip side, I think it's important to note some of those tumor types where there has not been as meaningful of an advance, and where there, even over the period where there has been some degree of improvements in certain types of histologies. For instance, I think hemangioma was one of the ones in the adults that did not show a great effect in terms of overall survival improvements, despite other tumors in this type, or other tumors in the adult as well as pediatric population showing some improvements. But I think it's, as you've also alluded to, I believe, over the last couple of years, it may be interesting to see whether or not there's going to be some sort of an asterisk during the COVID era, because of all the potential effects in terms of delayed diagnosis, potential changes in treatment approaches that may have been taken. And some of that has been published in the JNO and other journals, where individuals may have had to be very artful in how they were treating patients, or patients may have had a delay in diagnosis potentially related to COVID activity, but moreover, across the board, some degree of increased mortality associated with procedures and just in general with COVID in the adult patient population. So it may be challenging to see what the next few years hold in terms of the analysis, or whether or not there's some degree of if you will, reversal of some of the trends you've noted.
Mm-hmm.
Yes, I think that's going to be a really interesting thing to look into, and something that no one's really been able to look into in that large kind of scale with registry data yet. I think, next year we're finally going to be able to get access to that first year of data for the COVID pandemic. And I think for all types of cancers, we're going to be seeing a lot of really interesting work put out, kind of looking at differences in incidence trends for those few years, that we're still kind of dealing with now. So yeah, I completely agree.
Yeah, we already know that the cancer registry, larger surveillance groups have already alerted users of the data that there will be some alterations in some with the data from the COVID period. So we're prepared for that, because there might be some delays in cancer registration due to that. So we'll see what happens.
Oh, go ahead, Jason. Sorry.
I was just saying, one of the things that you said was that, none of us on this webinar necessarily has a clear understanding of what has led to some of the positive effects that you've noted. But as you think about investments in healthcare and frankly, investments in the time and effort of the clinicians who watch this webinar and read the journals, and the clinical researchers and basic scientists, we probably all feel as though to some extent we're contributing to that. Now where those dollars are best spent and and who's really made the meaningful difference is, I think something that in some ways would be incredible if one could tease that out. I realize that that's not necessarily falling in the scope of your analysis, nor should it necessarily, but so much time and effort and healthcare dollars and research dollars have been spent to try to improve outcomes for patients. I wonder if there are other opportunities to try to drill down on this. Do either of you have any thoughts on, are there specific activities or colleagues that are looking at this and trying to determine some of those potential causative factors for the positive or negative trends associated with this, or are there means by which that could be done?
So that's a great question. So one thing in particular that some of our colleagues have been looking into is the impact that Medicaid expansion has had on access to care. So kind of trying to tease out in these regions that receive this Medicaid expansion versus regions that didn't see that, or at least didn't see it as soon, if there were notable differences in survival and patient outcomes during that time period. So that's, a thought, a potential that as patients have greater access to health insurance, that they're able to receive care, they're more proactive in looking into care. So that's that was an idea potentially that could contribute. Not necessarily, would definitely not cover the entire, scope and time frame, but a thought.
We had a provocative webinar a couple months ago, and I'm sure Randy remembers this, by colleagues at University of Miami who looked at the disparities in healthcare and the relative access of healthcare, and specifically higher levels of care facilities around pediatric brain tumor patient population. So I agree. It would seem to me that as at least access is improved, you would expect some degree of earlier detection and outcomes. And they had some data that they extrapolated from another registry base that suggested that too. So it's certainly an interesting idea, and I'm sure there are other causative factors as well.
Oh, yes.
So we're approaching the 30-minute mark. I do want to say that to focus on a big positive here, I think, even though the improvement is incremental, it's improvement. And so like Jason alluded to, we're working hard at this, and people who do research and people who collect money to support research, and researchers and surgeons and everyone, are moving the needle. And that's a positive. And so we got to keep doing what we're doing without a doubt. I think it's a lot of power in big data, and you guys demonstrate that, and it's important to see and note. And so I wanted to thank you guys again for being a part of this. And we'll see you in a few years when the next one comes out.
Terrific.
Yeah, definitely.
Well, we hope to see more from the CBTR US in Journal of Neuro-Oncology, and obviously, great work. And I must say, any of those young individuals who are seeing this either in real time or accessing it, there's obviously tremendous opportunities from a career standpoint to get involved with the NCI and your organizations to try to broaden our understanding of overall epidemiology and changes. So, and I like the idea that you're so receptive to collaboration. So I hopefully some will arise from this webinar. Thanks so much.
Thank you. Thank you.
Perfect. Take care, everyone. Thanks so much.
Have a great day. Thank you.
Thank you.
Bye.